clinics with about NAFLD. And I'll be talking a little bit about pathophysiology and things like that, and a little bit about some of the work that I've been doing with primary care in identifying patients with significant liver disease. So to start off with a bit of background, non-alcoholic fatty liver disease affects approximately a third of the general population, so it's extremely common. It affects over 90% of patients with a BMI of over 35 and approximately 70% of patients with type 2 diabetes. It's the most common cause of liver disease in the Western world, and of course it's entirely preventable. But most people actually don't get any symptoms and will never get any symptoms related to their liver disease. Saying that, those who do are increasing in number, and it's set to become the most common indication for liver transplant within the next decade. And one of the things that patients come to me and say when I see them in the clinic, when they've been diagnosed with NAFLD, often totally asymptomatic, is, oh, but I don't understand, I can't have cirrhosis, I don't drink alcohol. And of course, that's entirely untrue. It's got nothing to do with alcohol. It's got a really stupid name. It's like calling a giraffe a non-elephant mammal, because everyone automatically thinks, when you say have alcohol in the title, even though it says non-alcoholic, people automatically think of alcohol. And really, that could be your next campaign for changing the name.
Changing the name.
Should be metabolically associated, metabolic liver disease, not non-alcoholic fatty liver disease. It's a ridiculous name. But having said that, alcohol can accelerate the rate of development of liver disease in patients with non-alcoholic fatty liver disease. So it is a factor to take into consideration. It's also a massively growing problem. So the UK has one of the worst obesity rates in Europe, and it's predicted that by 2030, 39 million adults will be obese. And approximately 10 to 15% of those are projected to develop liver disease with fibrosis and cirrhosis, so really advanced liver disease. So you can see that's a huge number of patients. And the other thing to think about is when they're going to develop it, because the patients that we're seeing advanced liver disease at the moment are in their 70s and 80s. These are people who grew up in the 50s in post-war Britain, where there was rationing and there was very, very low levels of obesity. Now we've got teenagers who are obese, and they will be developing advanced liver disease in their 40s and 50s, if not earlier. In Gateshead we have a particular problem because 68.9% of our adult population is obese. That's higher than the national average, and 38% of 10 to 11-year-olds are overweight, which is so awful. And 1 in 4 are obese by the age of 15. And in my mind, it's a form of national child abuse, really, that we're causing. We're condemning all these children to a life not only of liver disease, but of chronic diseases in terms of diabetes and other obesity-related complications. It's also a great source of health inequality, because those who are most vulnerable in lower socioeconomic groups are the worst affected. And as I'm sure you all know, this is a graph of standardised mortality in the UK showing how liver disease has massively increased, whilst all the other major causes of mortality, including heart disease, stroke, cancers, have gradually improved. It's now the 5th most common cause of death, and all the others are going down. Here's another illustration of the northeast in all its glory. So this is a map showing liver mortality, and the red dot is the Freeman. So you can see that just south of that, where Gateshead is, it has one of the highest rates of liver disease mortality in the country. So myth number 2 is that NAFLD is primarily a liver disease. Actually, it's a multi-system disease, and it's a disease of insulin resistance, and that's why it's so closely related to diabetes. And you can see this is a complicated diagram, but what I basically wanted to show you is how insulin resistance and the liver interact. So the liver is the organ which stores and uses glucose, and it stores glucose for the whole body. So when you eat carbohydrates, your body produces insulin, and when your insulin levels are high, it tells the liver to store the energy, and initially it stores that as glycogen, so that's the easily accessible form of energy, a bit like putting it in the fridge. And then once the fridge is full, once the liver is full of glycogen, it then starts storing it as fat, so that's like putting it in the deep freeze. And the thing to remember is, at times when your insulin level drops and you start using that energy, unless you empty the fridge and start going into the freezer, you're never going to get into this fat burning mode. And we're in a position now where in evolutionary terms, insulin was extremely important, because at times when there was food available, it would trigger you to keep hungry, to keep eating, make the most of the available food, store as much as possible as fat, so that when there was no food available, you could go to that storage and use it up. And obviously we're always in storage mode these days, because we don't get to the point where we don't have any food. And so our insulin levels are always high. And there's this loop that forms. So as you store fat in the liver, that makes the liver more insensitive to glucose, so that you need higher levels of insulin for the liver to do the same job. And then that creates hepatic insulin resistance, which again leads back to insulin resistance in the body, and you get higher levels of insulin still, and so it goes round in circles as more fat is stored. The other important thing that insulin does is that it also obviously causes you to lay down fat in other areas of the body. And fat is a really important source of inflammation. When you've got a lot of fat, they release a lot of hormone-like substances that makes you more prone to getting inflammation. And that's part of the reason why you get inflammation in the liver that leads to NASH, which is the more dangerous form of NAFLD. And this is, as I'm sure you're aware, there's a spectrum of disease in NAFLD. So the vast majority of people will be across here on this side of the diagram, where they've got fat in the liver, but it just sits there and doesn't do a lot. Still makes you more insulin resistant, and so you've got increased likelihood of developing diabetes, and it affects your cardiovascular risk. But a proportion of those, and it's more common in patients with diabetes and patients who put on weight, will have inflammation associated with that fat, and that's when you get NASH. And it's the NASH, so the inflammation and repair over time, that gradually leads to scarring, fibrosis, and eventually cirrhosis. But myth number 3 is that patients with advanced NAFLD are likely to die of liver disease. Actually, even in patients with cirrhosis, 85% of them will die of cardiovascular disease. So it's the cardiovascular risk from NAFLD that is really deadly. They've got double the risk of developing colorectal cancer and 6 times the risk of developing liver cancer. And in non-diabetic patients, it of course increases the risk of you developing diabetes because of the way it affects insulin resistance. And the main predictor of outcome from all causes of death in NAFLD is how much scarring, how much fibrosis there is. And this is from a large meta-analysis. So this graph on the right shows you all-cause mortality, so that includes all the cardiovascular disease and the cancers, and there's quite a linear relationship. The more scarring you have, the more likely you are to die of any cause. On the right is the liver-associated mortality, and obviously that is even more closely related. There's an exponential relationship between the amount of scarring in the liver and your likelihood of dying from liver disease. So the Lancet report on liver disease estimated that 18 million patients in the UK have NAFLD, but in fact only 600,000 are reported on GP records. So we're massively underdiagnosing non-alcoholic fatty liver disease. And this means that rather than presenting at a time where we can do something about it, patients are presenting at the end stages of liver disease with the complications. And these are some of the pictures of complications. So this is at Varix, so this is when you go down and you're doing an endoscopy. You can see the blood spurting from an esophageal varix. That's a picture of a liver with lots and lots of liver cancer, and that's somebody with ascites fluid in the tummy. And this is particularly the case for liver cancers, so 60% are diagnosed very late stages, and only 22% are diagnosed on surveillance, and that's despite the fact that we survey all our cirrhotics, and that's because we're not diagnosing the cirrhosis until we've got the liver cancer. And in the northeast, only 11% of liver cancers are actually treated with curative intent. The rest are palliative. So it's a really deadly diagnosis, and that's because it's diagnosed at such a late stage. So why are we not picking people up? I think there's lots of reasons. There's a lack of awareness. So it's a relatively new disease, and particularly people in primary care, so GPs, are not thinking about it. And for a long time, they've accepted slightly abnormal liver function tests. And as I've mentioned before, at the moment, this is a disease, because it takes so long to develop, it develops over 20 to 30 years, it's now occurring, and because of when we started getting a lot of obesity, it's now happening to patients in their 70s and 80s. And those patients will often have died of other things like cardiovascular disease. Now we're better at treating cardiovascular disease, and now that people are becoming obese earlier, the age at which we're recognising and having complications from liver disease is coming down. There's also poor diagnostic tests, so there's no really good test for non-alcoholic fatty liver disease, and I'll come on to that a little bit more in more detail a little bit later on. As I've said, there's a massive lag between the development of liver disease and when you actually present with complications, because the liver is so good at compensating that you can have significant amounts of liver damage without any symptoms at all. And it was thought previously that non-alcoholic fatty liver disease was just part of the metabolic syndrome and kind of a marker of metabolic illness rather than a disease in itself. It's also thought to be untreatable because we don't have any medications, but not having any licensed medications is not the same as it not being treatable. It's also seen as irreversible, particularly once it gets to the stage of cirrhosis. So what we've been trying to do is come up with some new pathways, mainly for primary care, to try and improve the identification of patients with liver disease and their management. And particularly, we've targeted diabetic patients because, first of all, they have a much higher risk of developing NAFLD. They also have a much higher risk of developing advanced disease. So they're a very high risk group, and also they're already having regular checks, so they're already having annual bloods, they're already known to the GPs, so they're an easy target. And we're trying to encourage clinicians who look after diabetic patients, and this is both in secondary care and in primary care, to consider the liver when they do their regular diabetic checks. So they look at the feet. We want them to look at the liver as well as the eyes, the cardiovascular risk factors and the kidneys, that's what the FLEX stands for. And we want to try and get as much of the management into primary care as possible, because this is a massive burden of disease. It's very, very prevalent, and so dealing with it in secondary care as the numbers grow is not going to be feasible. It really needs to be done in primary care. So the problem, part of the problem, is that this is a myth that exists from everybody, from patients through GPs, through to secondary care physicians, through to gastroenterologists, that if your liver tests are normal, you don't have a problem with your liver. And that is not true. So the liver tests that we do are liver enzymes, and they do go up when you have significant inflammation in the liver. So if you have autoimmune hepatitis, for example, and you've got severe inflammation, then your ALT will be very high. But that is not how NAFLD works. You've got a low level of inflammation going on over a number of years, and that does not necessarily cause any significant rise in your liver function tests. And so it's quite feasible that someone will have totally normal liver function tests all the way through and then present with cirrhosis. And it makes it difficult to get patients to come for tests for fibrosis and things, because they've been having regular liver blood tests and they've always been normal. So they say, there's nothing wrong with my liver tests are normal. There's also, as I said, no simple, reliable way of diagnosing non-alcoholic fatty liver disease. We've got ultrasound, which is good if there's more than 30% of the liver is fat, but it's got very poor sensitivity below that. And it's also not, you can't go around doing ultrasounds on everybody because it would be expensive. And liver function tests, as we said, 50 to 80% of patients with advanced liver disease will have normal liver function tests, so that's no good either. So liver biopsy is the gold standard, and obviously that is invasive, expensive, and you can't do that on a significant number of patients. So we need to find new ways of identifying these patients. There's also contradictory guidelines. So at the moment, the BSG and the NICE guidelines don't specifically say that you should screen any particular group of patients for non-alcoholic fatty liver disease. They do say that you should not use normal liver function tests to rule out liver disease, but they don't really give any guidance on what you should use. Whereas the European guidelines suggest that everyone that's high risk, such as diabetics, should have an ultrasound and liver function tests. And that also is not particularly workable for the reasons that we've said before. So what we're doing at the moment, if there's any evidence that someone has non-alcoholic fatty liver disease, be that abnormal liver function tests, or they've got a fatty liver on an ultrasound that they've had for some other reason, or they've got a low platelet count. Low platelet count is a really good marker of what we call portal hypertension. So when the liver gets scarred, the blood gets diverted and goes to the spleen, and the spleen gets bigger, and the spleen's job is to break down the platelets, so they break down more platelets and you get low levels of platelets. So that's a marker of quite advanced liver disease. Then, particularly if they're in high-risk patients such as diabetes, then people should think about non-alcoholic fatty liver disease. And then they're supposed to have a clinical review, be asked about other risk factors for liver disease, see if they've got any clinical signs of liver disease, and have a full liver screen, so test them for PBC, autoimmune hepatitis and viral hepatitis, and all those things, and include a score, the FIB4 score, which is based on some of the liver blood tests combined with the platelet count and somebody's age, and gives you a score which has a very good negative predictive value for advanced disease. So if your score is low and you're in the low risk category, it's got a 96% negative predictive value, so there's only a 4% chance that you've got significant liver disease. So that's a really useful initial test for patients who you think might have non-alcoholic liver disease, and you do an ultrasound scan. So staging the disease, you do the FIB4 score. It's free because all the blood tests are done anyway. So it's on the routine blood tests. It can be requested by GPs or the HCAs who are doing the chronic disease monitoring. It gives you a score, and we've now at the QE in Gateshead, the GPs or the practice nurses or whoever's requesting the test can request it as one of the tests on ICE, and they get a result rather than having to work it out. You used to have to put it into a calculator and things. They get a result and a prompt with what to do. And essentially, if it's anything other than low, then these patients need another test, which at the moment we're using a FibroScan. I don't know if you know what a FibroScan is or seen it work, but this is what it looks like. It's basically like an ultrasound machine, so it's like a jelly scan, but it uses a special wave that is transmitted through to the liver. The liver then bounces the wave back, and it measures the strength of the wave coming back. And the more scarred the liver is, the stronger the wave that comes back. And you get a reading, and you can decide what cutoff you want, whether you're looking for really advanced disease or whether you're looking for moderate disease, and it helps to stratify the patients in terms of risk. The work that we've been doing here in Gateshead is really around screening for high-risk patients, so particularly diabetics, because if more than 70% of diabetics are affected, then you're going to get quite a decent hit rate in terms of screening. The reason that it's not recommended yet by NICE specifically is because of the lack of cost analysis. So the resources are an issue, the fact that there's no ideal test for the disease, even though we've got quite good ways of staging the disease. and because a significant number of patients with NAFLD actually don't go on to develop any clinical liver disease. So we've been piloting a scheme in a couple of practices in Gateshead looking for advanced liver disease in diabetics, where at the time that they have their diabetic review, they also have a FIB-4 score, and then if their FIB-4 score is high, they then come in for a fibre scan. And these are not the latest figures. I had a copy of the talk, but essentially we've now done about 475 type 2 diabetics, but the proportions are more or less the same. So about 10% have a high FIB-4 score and need to come in for a fibre scan. And about a quarter have a liver stiffness that suggests they've got cirrhosis. So that's a significant number, and we've diagnosed quite a few, about 20 patients just in these two practices that had undiagnosed cirrhosis. And the other quarter, another quarter have at least moderate fibrosis, and the rest of them we can discharge back to the GP because they don't have significant fibrosis. So in the in Gateshead, this would approximate to about 400 new diagnoses of cirrhosis, and another 300 odd with significant fibrosis. And the cost, it's very, very cost effective because the FIB-4 score is free. That gets rid of most of the patients anyway. The fibre scan we're going to have as direct access from the GP, so they can, and the results going back to the GP. So it's about £37 for a fibre scan. And a lot of these patients will have been inappropriately referred into clinics before for these investigations. So actually you save a lot of money not seeing lots of patients who don't have any significant liver disease, and you're actually seeing the right patients, the ones with significant liver disease. Those who have a low FIB-4 score are sent back to the GP, and they have another FIB-4 score done in a few years' time, 3 years. Anyone with advanced fibrosis obviously comes to us, and they get either a biopsy to stage them if needed, or we just start surveillance if it looks like they've got cirrhosis. So then I was going to talk a little bit about management of patients. Another couple of myths here, that there's no effective treatment for non-alcoholic fatty liver disease, but there is, it's just not medication, and that liver fibrosis is irreversible. So neither of these things are true. It is about lifestyle, it's all about lifestyle modification, as well as optimization of all the other cardiovascular risk factors like diabetes. We know weight loss is the key. We know that 10% of weight loss can reverse fibrosis by a whole stage. So in terms of fibrosis staging, it goes from 0, where you've got no scarring whatsoever, up to 4, which is cirrhosis, and the other 1, 2 and 3 are in between. And you can go down by a whole stage. That is a large study done with 10% weight loss. There's a LIVErNORTH booklet on dietary advice, which is excellent, or you can refer to a dietitian. The only thing is that the problem is that a lot of dietitians are not specialist in this area, and a lot of them are there to try and put weight on people rather than give weight loss advice. It's a different type of service, and unfortunately there used to be weight loss services in Gateshead, and all the funding was cut, so now there are no weight loss services whatsoever. Very, very short-sighted. There are various specific diets which have been shown to be effective. Low carbohydrate diets, because of the effect they have on reducing your insulin levels and therefore improving insulin resistance. Mediterranean diets, very low calorie diets, similar to those used in the reversal of diabetes. We also need to think more probably about bariatric surgery, so that's something that often doesn't cross our minds, but that's very, very effective mode of weight loss and can have dramatic effects on non-alcoholic fatty liver disease. And exercise is also really important. So exercise, even without weight loss, has been shown to improve liver fibrosis, and that's both cardiovascular exercise and resistance exercise. Controlling diabetes is really important, and you can tailor diabetes treatment to help improve the fatty liver disease. So there are drugs that are good for patients with fatty liver disease, and there are drugs that are not so good. Metformin is good because it helps to lose weight. Pioglitazone has been shown in trials to improve liver fibrosis. Similarly, some of the new ones, GLP-1 receptor agonists, the raglutide, and then loads of ones that I can't say, they all help with liver disease. Gliclazide, which is one of the older drugs, tends to make you put on weight, and that's not so good for patients with NAFLD. And insulin is a problem as well, because insulin kind of tends to put you in that cycle. When the problem is high levels of insulin anyway, giving more insulin can perpetuate the problem and also makes you put on weight. So avoiding insulin unless it's needed, obviously. You need to treat blood pressure, and ACE inhibitors, which are one of the first lines for blood pressure anyway, have also been shown to have beneficial effects on the liver. In terms of alcohol, we advise patients to just drink within the current limits, less than 14 units of alcohol a week. They don't need to be abstinent, but they have to be aware that drinking to excess on top of their liver disease will really accelerate the development of advanced liver disease. And you tell them to stop smoking. We get a lot of questions from GPs about statins, and they are totally safe in patients with non-alcoholic fatty liver disease. In terms of monitoring, they just need their regular annual blood tests, as they would have for diabetic review. You need their lipids, monitoring their blood pressure, weight and waist circumference is important. And then we just ask the GPs to calculate the FIB-4 score every 3 years.
Are these standard tests that were done across the country, or is it something which is specifically Gateshead?
No, so the FIB-4 score is part of our local guidelines.
Yeah.
In terms of all the others, any patient with non-alcoholic fatty liver disease should be having these checks. And even if they're not diabetic, they need to be checked for diabetes every 6 months to a year. Because the risk of them developing, essentially NAFLD is a pre-diabetic condition. Yeah. So by definition, if they've got NAFLD, they've got insulin resistance. There are also some drugs that we use, mainly in secondary care, and these are not licensed medications, but they have, in trials, shown to be helpful. So vitamin E, something you can buy at Holland & Barrett, it's supposed to make your skin young, as well as helping to improve liver fibrosis, and you can use that in patients with NASH, so actual inflammation, or with fibrosis. Pioglitazone, usually used in diabetics, it's one of the diabetic medications, and there are a load of new trial drugs. I have my concerns about drugs. One of the issues is that usually in trials, the endpoints are clinical, so mortality, whether or not you die, and what you die of, heart attacks and strokes, for example. And the drug companies developing these NAFLD drugs have been quite clever in that they've kind of managed to move the goalposts quite a long way away from clinical outcomes, so that in order to get approved, they just need to show that they improve either liver fibrosis or non-alcoholic steatohepatitis. When actually we don't really have the evidence that just improving that in isolation, if you're still obese, have diabetes, have high blood pressure, whether or not that really is going to help. Whereas weight loss obviously improves all your risk factors, and so will definitely have an improvement on mortality. And so I do have concerns that these will be advertised as a panacea for non-alcoholic fatty liver disease, when really we may be missing the real, the best treatments, which will be lifestyle. So how are we going forward? We're in discussions with the CCG at the moment to roll out the screening programme for diabetics across Gateshead. And there may be an argument to extend this to other high-risk groups, so people with other factors of the metabolic syndrome in the future. One of the problems that we've had in the pilot is getting patients to come for FibroScans. So, as I said earlier, they don't think there's anything wrong with their liver. They've been having liver function tests for years. They don't have any symptoms. Their liver function tests have all been normal. And importantly, they've been told by their doctors that their liver is normal for many, many years. And so for suddenly someone to say, there's a chance that you've got significant liver disease, can you come for a scan? You've got to take a morning off work or whatever. Then a lot of them just say, no, thanks, there's nothing wrong with my liver. There's an alternative test called the ELF score, which is a blood test, enhanced liver fibrosis score. And it's not used in this region, but there's been a recent paper from Camden Islington in London where they use the ELF score as part of their abnormal LFTs pathway. And the advantage of that is that it's a blood test, so anyone can do it, you don't need to be trained to do FibroScan. The patient actually doesn't need to come in at all, so you could envisage when they're having their diabetic review, they could have the FIB4 score done on their normal bloods, because you don't need any extra bloods taken for that. And then if they've got a high result in the lab could automatically send it for an ELF score and then give both results back at the same time. So that really would streamline the patient pathway and reduce the DNAs. The other problem that we have with FibroScans is that you can't get a reading on some people, either because of their weight or because their ribs are too close together. And so it's quite difficult in someone who has normal liver function tests, who's just got a raised FIB4 score, who you can't get a liver FibroScan result on, to then say, right, well now we're going to need to do a liver biopsy, which is quite invasive. So the ELF score would be a helpful additional tool. So we're hoping to do a research study looking at the use of ELF as part of this pathway to try and introduce it somewhere. We're establishing direct access FibroScans for GPs, so that means that the GPs will be able to request the FibroScans and then get the results themselves, and that will reduce the need for the patients to come to outpatients for a clinic review, and keep as much of it in primary care as possible. And also, I think we really need to be better at giving lifestyle advice. And there are lots of problems around the lifestyle advice we give. So where can the patients get this lifestyle advice? This is, you know, keeping in mind that this is the only treatment that we have. They come to us and they could get the booklet, which some of them may read, some of them may not. They get what could be considered a brief intervention from whatever clinician is seeing them. And if that's a hepatologist, it's usually someone who's not got a particular expertise in diets. They may be sent to a dietitian, but there are very, very few weight loss dietitians, and so it's not their area of interest or expertise either. There's no funded services, so they're on their own, really. And so another study that I'm hoping to do, I'm putting in a grant for LIVErNORTH, is to incorporate that into the pathway for liver disease. So all those patients who come through who we identify as having at least moderate fibrosis, so significant liver disease from their NAFLD, would then go into a structured lifestyle programme, like a 12-week lifestyle programme where we go through diet, activity, stress, sleep. These are all things that really affect your metabolic health, and see whether or not that improves their outcome, with a view maybe to that being an alternative for some patients to coming into secondary care. Obviously those with cirrhosis need to have secondary care input and regular follow-up, but those with moderate fibrosis that we don't really do anything with, it would be far better for them to then go to a lifestyle programme and then be reassessed, and then maybe they could stay in primary care. So that's it. I don't know if anyone's got any questions.
It's great to hear all these new ideas. Because when it's figures are very stark, aren't they, about the numbers of people affected? affected.
Yeah, it's a huge problem. It's going to be a massively increasing problem. I did have, I think I'm unfortunately uploaded the wrong version of the talk, but it's predicted by 2020 that 70% of women and 80% of men are going to be obese, and that about 10 to 15% of them will get liver cirrhosis. So it's going to be a huge problem, and it's very difficult in the current climate, in terms of funding and things, to get anyone to see beyond tomorrow. But it's going to cost the NHS huge amounts of money, and obesity as a whole is going to completely cripple the whole system, so we need to be addressing it. And really, the most cost effective and the best way of doing it is to introduce it into schools and target children, because the obesity levels in our youngsters is the most concerning thing. And there's a recent study in Bristol. They've got a cohort of thousands of youngsters who they've been following up since birth. So they recruited the mothers when they were pregnant, and then they've been following the children up. And those children are now in their early 20s. And they screened them all for NAFLD, and about 20% of them had non-alcoholic fatty liver disease already in their early 20s. And a very small number of them had evidence of fibrosis already. So it's something that is going to hit us eventually, but getting the people in charge to take a bit of a longer term view, even getting them now to diagnose cirrhotics, they worry about the cost of having to do surveillance in the patients who identify with cirrhosis, because the cost of identifying them is very, very minimal. All the costs involved are through the surveillance of them. So there's a problem with some short-term thinking, and that's something that we just have to keep trying to work against. And I think public health policy and things like the sugar tax and improving the balance between the availability and affordability of junk food versus healthy food is something that I think is really important for the government to lead on.
I think in schools, I'm speaking now as a NASH patient, and at the sort of the top end of the three.
Right.
So I've got bridging fibrosis.
Yeah, okay.
Professor Anstey's patients.
Mm-hmm.
And obviously that there are a couple of issues. I know in schools, because I've been in schools for a lot of years, and we've always tried to, we've got LAF programs and things like that lifestyle type programs and what have you, and try and encourage our families to sort of and our children to look at the sort of the healthy lifestyle. Yeah. But obviously, I don't really know how to express this, but life is becoming more and more complex, and food is linked with mental health. We've got a real major issue with mental health, okay, in our schools with our young people. And all the population. So there's a link there. I firmly believe, I was never obese. I'm diabetic. When I was in my 20s, I was diagnosed with polycystic ovarian syndrome, so no insulin resistance. So there's always been a bit of an issue there, but I also had a very stressful job. And the way I am as a person, maybe I took a bit of that stress on sort of physically, as opposed to sort of mentally, do you know what I mean? But my brother was diabetic, my mum was diabetic, I knew what, I didn't drink. I couldn't drink, because if I had a drink, I started to itch. There was something
there's definitely
crying out,
genetic
right?
component,
Definitely. But the stigma, and I do say this, I think, the worry is that it was great hearing you talk about the myths, and I can tell by your stance that if I came to you as a doctor, I wouldn't feel stigmatised. But there is a stigma around even the terminology non-alcoholic fatty liver disease.
It's a stupid name.
And you sort of, if you trying to explain
It's
to
got
somebody.
alcohol and fat in it.
Yeah.
I mean, it's like creating stigma all by itself.
Yeah. Well, and I just worry. How do you get over that? Because I understand about the lifestyle thing. I've tried all my life.
Mm-hmm.
Do you know what I mean? I've always, and
Well,
I've
you're
never
not
eaten a lot, and,
Yeah.
and you know, because there was diabetes in the family, I didn't want to go on insulin. Didn't want to be diabetic. I was diagnosed exactly one of those people where the GP, ALT, diabetic tests, ALT, slightly raised, you were all right, wasn't overweight, it was fine, I was working,
Mm-hmm.
all of those things, and on and on and on, and it was a fluke that I was diagnosed,
Mm-hmm.
just a sheer fluke, and I was fortunate when I was.
Yeah.
But I remember one of our, sadly she's passed on, Tilly, was one of our PBC patients. And she said to me, when I was getting diagnosed, because LIVErNORTH, when I first joined LIVErNORTH, it was predominantly sort of PBC,
The rare diseases.
the rare ones, you know what I mean, and NAFLD, and actually, I sort of felt a little bit, you know, sort of like trying to be a little bit of a sort of low profile, because I thought, you know, because I'd been to a scan where they said, oh, a typical Geordie liver, never eaten plastic, and I'm never trying a brown ale. And I didn't want to go back to see the doctor. I was fearful of going back to see the doctor because I was embarrassed. And I was a head teacher. How can you be embarrassed when you sort of stand in front of kids? But it was saying something about me. And I think our young children